Good morning. Welcome to live case session number 6. I am co-moderator David Cohen from the United States, and my co-moderator to my right is Bangkwan Koo from Korea. We have a distinguished panel. We're here, and I think the case is ready to go. And my understanding is this will be Dr. Young's case from the Asan Medical Center. So if we could have the live transmission, please.
Okay, let's move to the Alan Young's live room.
Good morning. Hey, Alan.
Hi, David.
How are you?
How are you?
I'm good.
And we have a great team here, and we are just here to put some wires in and add some IVs, and we're going to go ahead and tell you about the case as well as what we have done so far. Not very much, but just I think it will be helpful. So okay. Dr. Lee is with me from Asan Medical Center, and he has been instrumental in really getting everything organized, as well as the IVIS team, the assistants. So let's, Dr. Lee, tell us what this patient is about.
Okay, we have a 69-year-old female patient here. She presented to our hospital with shortness of breathing lasting for 6 months. And we already performed the coronary angiogram. The RCA was relatively okay. And she had significant stenosis at the proximal portion of LAD and some disease extending to the left main. And you can see another tight stenosis, maybe a tight stenosis at distal portion of LAD. So another concern is that there is a diagonal branch at the lesion itself. So I think there would be lots of discussion points in this case.
So the interesting part is that she has, obviously no stress test, but dyspnea on exertion, but not angina, right? So in a sense that you have to sort of say this is symptomatic with dyspnea, angina equivalent as dyspnea.
Right.
We don't have any other sort of, ischemic index before go to cath, but nevertheless the angiogram has been done about a month ago or longer ago?
Yeah, a month ago.
A month ago or so. So can you see the angiogram, David?
Yeah, we can see it. We see a tight calcified proximal LAD stenosis involving the first diagonal.
Right.
You don't have to convince me very hard that that's going to cause ischemia.
Right. So that's pretty straightforward, from once you have the angiogram. So I don't know, can you see whether there's another lesion downstream and also the left main?
That's harder to appreciate.
Okay. Can we go back to the diagnostic angio?
Okay.
Because we didn't take that many pictures.
Diagnostic angio.
It's right here. Yeah.
Right.
So you can see it, David, and you can see that there is a tight proximal lesion, some calcification. Left main may be a little taper at the origin. Next view.
Okay.
Do we have the diagnostic picture?
Okay. Yeah, I see the diagnostic picture now. We can see a more distal lesion, more moderate, not as severe as.
Oh yeah. Okay. They see it there. So you can see that there is a sort of a moderate lesion in the mid portion of the LAD.
Yeah.
The circumflex looks pretty clean, and the diagonal is a longish vessel, but relatively small in the diameter and origin. So the question is couplefold: is that do we need to go ahead and fix the mid LAD first, and then do the proximal LAD? And also, do we need to treat the diagonal, as well as what are we going to do with the left main? In this view, you can see, David, the left main has a little bit of tapering.
Yeah, you can see
reverse tapering a bit. So it's certainly at the origin, there's some disease. How much is hard to know. Originally, we were supposed to demonstrate some physiology here, but I don't see any reason to go do FFR in this lesion right now. It looks really tight, and there's multiple lesions, so you can't really assess the lesion that well without fixing at least the most severe lesion. So that's kind of what we have.
Okay.
The approach we took, do you want to discuss and what you want to do, or I can show you
No,
what
I
so far
think begin. Go ahead.
So Alan,
Yeah,
this is Guan speaking. So that the one thing I would like to comment is that the importance of left main in this case may be very important, because you have to set the proximal location of where your proximal stent edge is. And from angiogram, I see that considering the size of the discrepancy between circumflex and left main, there should be some diffuse disease in left main in addition to the ostium. So that may be the one important aspect we should consider. when we see this
Yes.
angio.
Yep.
Yes.
And what size guiding catheter is that you have in? Is that an 8,
So-
7?
7 French.
We went from the groin, was originally going to put an 8 French in, but I think we can just go with the 7. So this is 7 French, EBU 3.0 is a lady, relatively small in size, and 3.0 so far seems to fit pretty good. So we don't think we need to protect the circumflex, so we kind of leave the circumflex alone, and we put 2 wires in, 1 wire in the LAD, and 1 wire in the diagonal. Both are run-through wires. And the first thing we want to do is that we want to take a look at the lesions by IVUS if the lesion allows us, meaning that can we pass an IVUS through this very tight lesion. So this is what we were doing before we came live, and we can show you the IVUS.
Right.
So this is the proximal LAD lesion?
No, this
Both.
is the distal portion.
This is distal, okay, thank you.
We're
Yeah.
distal to the mid lesion.
Okay.
So you can see the, if you want to adapt, do you want to tell us what you see, or?
Just
Up to
tell
you.
them, Yeah.
So,
Sorry.
so there is a fair amount of disease already. This is distal to the lesion. As we get a little closer, there is a branch, probably a septal, and then you get a pretty tight lesion.
Packed in there tight, yeah. Not too
Yeah.
much calcium there.
Not much calcium, only about 60 degrees or so. And then this continue to have some disease there. A little bit more calcification there.
Yep.
And then it opens up to an area that is relatively a little bit more normal, but it's still disease. And then this is open up a bit more.
Was it difficult to get the IVUS through the proximal lesion?
A little bit of push, a little bit of guide.
A lot of plaque there.
Yeah, a lot of plaque. And now we are kind of in between the lesions. We'll be seeing the proximal lesion very soon.
And the patient ECG were okay during the IVUS procedure.
Exactly. We were watching carefully, making sure chest pain, because it's a very long pullback, so we don't want to have her get ischemic in between. We debated whether we should pre-dilate first, but we didn't know when we were coming on, so we didn't want to pre-dilate and has a problem and then have to do the case type of thing.
Very fibrous there.
So this is the proximal lesion.
That's a lot of calcium.
And pretty tight. So obviously, if we're going to stent this, this is a diagonal coming at 6 o'clock. A little bit of disease in the origin as well.
A lot of calcium.
Now it opens up a bit. Circumflex is coming at 6 o'clock.
Yep. So with all
And
that
then
calcium,
you see the left main.
do you think you need to do anything other than balloon it? Do you think the balloon is going to respond well?
I think so. I don't see that it was completely, napkin ring yet.
It wasn't a napkin ring, no. But it was a
Right.
good 180 degrees at least.
Right. So we definitely need pre-dilation because it'll be hard to really look at anything beyond this lesion. And so the question originally we were talking about this case is that we're going to dilate proximally and then fix the proximal to left main and then maybe FFR the mid lesion to see whether it is significant or not. I think we have to change our plan a bit.
Right.
I think that from the IVUS, and also if you look at a different view of the distal lesion, the mid LAD is quite tight.
I mean, certainly
So
there
we
was,
are going to go ahead and basically pre-dilate the mid lesion, pre-dilate the LAD, proximal LAD, and then we should stent the mid lesion. I think we measured it to be about 28 to be normal to normal mid lesion.
Yeah, right.
3.0 maybe for the, and we can post-dilate it more. And then after that, we measure the proximal part of the proximal lesion. The question is that do we want to stent into the left main and all the way back to the ostium, or we sort of leave it in the mid portion or the ostium of the LAD?
So did you do some measurements now? Is that what's going on with the left main?
Yeah, so the left main, we were coming on before we measure, so we were doing some measurement now. So the, what is the proximal,
Proximal portion.
length?
Proximal portion length.
Yeah. 24?
24.
So the distal lesion actually longer.
Right. From normal to normal.
Yeah, from more normal to normal area. So the proximal area, I would say the stent is at least start with the distal reference is about 3.5. And then we can post-dilate the left main to whatever size we want.
Right.
So, Arlene,
What do you think?
so you don't want to do the measurement of the physiology or the FFR in the middle RAD? From the IVUS
if
finding?
you look at, yeah, the IVUS finding looks really almost occlusive to the lesion, because if you look at different view of the, I think an aleocranial view
Yes,
that
right.
I'm not sure you saw,
Right.
Aleocranial, it
Aleocranial.
looks very tight, right?
very tight. So
Aleocranial.
it's quite eccentric. So I think it's probably here.
Here.
Can you see it
Yeah, we can see it.
on the screen?
I'm going to
It's
tell
pretty
Bill.
tight.
I'm going to tell Bill Fearon though that you didn't do FFR.
We're doing FFR in the circumflex. How's
Okay.
that?
All right.
Okay, okay.
Okay, let's go ahead and get a balloon. Let's get a
Okay.
3.0 balloon, maybe
3.0.
just a regular balloon.
A regular.
I like a 3.0, maybe 12 or 15.
You have a question?
I just have a quick question
I
here.
don't think your microphone is on. I don't know. Is there? Steal another mic.
Hello?
There you go.
It's a compliant balloon.
I just had a
Three-wheeling.
quick observation here. The proximal lesion is quite calcified, and the diagonal which you're protecting with the wire now is coming quite close or off that lesion. It's almost a bifurcation lesion with calcium. Do you think that maybe debulking it first with something rotational, like rotational atherectomy, may decrease the chance of carinal shift and side branch compromise here, especially given the angle is pretty narrow as well?
Yeah, I think you are correct in the sense that the bulking the LAD or even the diagonal bit origin would probably be helpful. Again, obviously clinically, we hopefully that it would not close after we'll assess how it looks. And the question is that, is it big enough to warrant a separate stent in the diagonal right off the bat?
Yeah, I think the trick with doing rotational atherectomy here is that the calcium is fairly deep, and so I'm not sure you would really ablate it very well. I guess that would be my main concern of it, because it certainly is heavily calcified.
So I'm going to stick a 3.012 balloon of some kind.
15 balloon.
Do you have 15?
Yep.
And this, can you do a test?
Test.
Pretty occlusive here.
You found it.
There. Okay.
Okay.
Go ahead and inflate.
Inflate.
So, Ellen, this is a 69-year-old lady. So, if the patient is 59, would you consider implanting BRS for this distal lesion?
A little bit more. 6, 8, 10,
8,
12.
10.
That's good. Sorry, we're just looking at the waist there for a second.
Okay,
Down.
that's fine. So that if the
So
patient is 59,
yeah,
yes.
I know. I don't think so, because we're talking about we're talking about pretty long stents in both. And again, we're given the recent data, I'm a little cautious, and therefore I would probably not do a BRS at this point. Let's change a different view. I'm going to dilate the proximal.
That might be a place where you need a graft. Is that why you're proposing the mid one?
Because in Korea we are more liberal to use of the BRS because we are strictly using the image-guided and strictly follow the PSP. Still, we don't have that kind of bad signal from our data.
Little test.
Well, everything works in Korea. That's my observation.
Okay, go ahead.
Everything works
So
well
we
here.
dilating, changing of view, we squish back, so it tells you that there is some lesion that is pretty tight there. Okay, I'm going to go in a little distal. Go ahead, inflate, slow.
Inflate.
I'm going
Slow.
to push a little bit, yep. Go ahead.
Inflate. Okay.
Doesn't want to
Something
stay,
doesn't
does it?
want to give, yeah. It tells you that you might need a bit of debulking or something
Cutting.
more.
Would you consider
Right
use
here.
a scoring balloon, Ellen?
Yes, yes.
4. Okay.
So what size of the balloon?
It's 3.0.
It's a 3.0, the same balloon that we had from the distal. Now it's better.
Now it works.
Yep, it works.
Good.
Sorry, yep. Down.
Down.
Still have the proximal.
So sometimes it goes slower, and a little bit of forward pressure may help to get, let me take a look in, because the 7 French I can see,
Okay.
and see whether we got the lesion and whether we need to dilate more. Picture?
Picture.
Sorry.
Oh.
So we see a dissection
Yep.
in the bottom of the LAD distal to the lesion, right?
Yep, you can see it.
And so the question now is that do we want to pretty much do a stent here pretty quickly, or should we just, now the lesion is longer than before.
Right.
Are you going to stent the distal one first?
Yeah, I'm going to go ahead and stent the distal one. Let's take a 228 3.0.
Okay.
And I actually would like to, if we can, still IVUS the left main, because the left main we didn't really get a good look at it. And the question is whether we just cover it. I mean, we can just cover it without any issue and just deal with that from that point on.
It may be simpler than trying to get the ostium exactly. That's so hard.
Yeah, it's so hard here is that, now we have an extended dissection. So how long do we want to put the stent in, right?
Even the ostium seems to be, not that clean, compared with the previous angio, so that there should be something happening.
So it's, I think we are moving ahead to stent the middle, and we can always post-dilate the middle later if need to. It's not a big issue. And then go ahead and stent the proximal lesion. And maybe aiming just go ahead and stent the left main.
What stent have you selected, Ellen?
I'm using a Resolute Onyx stent, a 3.0, because it really can go up to whatever size you like. So I feel very comfortable that I can post-dilate further
And for
and get
Resolute,
into
we have 26.
26.
I think this
26
case,
3.0.
this case really illustrates the usefulness of IVUS to plan the treatment strategy. So it looks small vessel, but when we see the IVUS, it wasn't a small vessel actually, it was quite large vessel, and the lesion lengths have been totally changed compared with the angio-guided determination and IVUS-guided determination. So that you can cover a whole lesion with a large stent, which makes a good prognosis to the patients.
Exactly.
So how big can you take this? We don't have the Onyx obviously yet in the U.S., so how large can you post-dilate this? 3.0?
Easily to 3.75 to 4.0.
Okay.
We are just really getting the Onyx in the U.S. right now. So let me see a little bit more of the guide and everything else, the wire and everything. Sorry. Make sure my wire is not too distal. Okay. Pull back a little bit.
And so this is also the one that has the extra layer, so you can see it more radio opaque, right?
Right. So maybe helpful in here.
It's nice to be able to see it resolute. Yeah.
Okay, so I need to do a little test and see how far we are, whether we're accurate. Ready?
Okay, ready?
We're off a bit.
Okay.
Let me do one more picture.
One more picture.
Okay, ready? Okay,
Sorry.
sorry. You get it. Sorry. One more time.
One more time.
Okay.
What do you think?
I'm trying to figure out where the thing ends.
Yeah.
Can you play the last shot?
Yeah. Yeah.
Okay.
We're going to replay the last shot.
Looks like distally it's covering everything. And
Yeah,
I think
I
just
think might
here-
come back a little bit because might as well use the stent to cover the relatively normal. Okay, a little test.
Test.
Okay.
Yeah,
I think that's good.
Yep, I think it's good. Go ahead. Okay. Inflate. So 8, 10,
8,
12,
10, 12,
13, 14, 15.
14.
Yep. Down.
Down.
It's a nice generous size.
Yeah, hopefully 3.0 is not too big, but it looks
the
like it's okay.
IVUS says it's okay.
Yeah. Okay. So you can see the stent quite nicely. I'm not used to Onyx too much because, as David said, we just really try to start to getting it, but clearly much more visible than the previous generation, right?
Yeah,
The
no.
strut is not thicker, but you have the platinum inside. So you can now post-dilate if you need to. Let's do one more inflation. I like that hysteresis to make sure everything is well expanded.
12.
Good. Okay, down.
Down.
Okay. So I'm going to park it here for a minute and take a picture, make sure it's okay. I'm going to then try to fix up the proximal one. Ready?
Ready? Okay.
Nice.
Nice.
Very nice.
Yep. A little pinch
So
on the
you see that there, a little diagonal. We'll give it a little nitro, a little wait, a little time. So the interesting thing is that if you look at IVUS, there's disease all the way back, actually in between.
Yep.
So the question is almost that you want to leave any area uncovered by stents, and it'd be actually interesting. I actually don't mind if everything's stable, is to do another IVUS and see how the length is, the dissection, has it changed the length, and also want to look at the left main a little bit more. So everything is stable. If it's not stable, I would just go ahead and stent and just forget it, whatever it is. But if it's stable, I think giving a little bit more time to look at that left main and so forth, give us a little bit of accuracy. What do you think?
I think a good idea. I think you have the time, and we have time here, I think, on the panel, and you can get the best, the perfect length, hopefully, of the next scaffold. Anybody disagree with that plan?
No, don't disagree. But I mean, you had the balloon there, the delivery balloon. You could easily use it to also gauge the length of
measure the length of
proximal stent pretty accurately. And I think you're obliged to treat the left main. You're not going to be able to park a stent at the ostium of the LAD here. You're going to have to cover the ostium of the LAD. You're going to have to stent back into the left main. So I think treating the left main is already a given.
Right. I mean, it may be your smartest thing to do is to plan where you're going to have your overlap so that you don't have two layers across that diagonal, I think.
Right. So we want to, really plan out this well if we can. I think the poor man version of just using that previous balloon, that was what I was planning to do if I'm not going to IVUS. But I think IVUS will give us a little bit more, and also it's educational, see how that dissection looks like on IVUS as well. I'm not so much concerned about the stent distally because I think it's maybe a little underdone and we're going to post-dilate it a little bit later. We're just going to take a quick look at it.
So Alan, after this IVUS, we're going to switch over to the other room. I'll let you guys do a little work and then come back, I hope.
Okay. So let's go ahead and pull back, and I'm going to pull the guy back a bit so that we can expose the left main.
Okay.
Okay. Can you give me a little test, make sure I'm outside of the...
And where are you now?
Yeah. We are just coming back into the stent. You see that,
Yep.
IVUS? So the stent is actually pretty well expanded. We missed a little bit of distal part, but we'll come back to it. But you see there's plaque there.
There's plaque everywhere.
Plaque everywhere. Plaque here, plaque there, plaque everywhere. So the question, where's the reference? We can land anywhere here, but we have to be careful, not dissect it, right? Because we land it in plaque, we have to be a little conservative. We don't want to make it flare and have a dissection, and then, then you have to put another stent in.
Right.
This is definitely need to be treated there. I think earlier it probably can be left alone. We're going to measure some distance a little later. I don't see much of the dissection yet. It may be underneath the plaque at 6 o'clock, 7 o'clock.
Don't see much, no.
Oh, no.
Dissection at the There was a dissection at 3 o'clock.
Yeah. It goes around.
Right.
Now I think see the dissection now is from about 6'5", and it just hang behind the calcium a bit. So here the length is going to be determined, and then as well as left main disease, and determine basically size of the stent, length of the stent.
Well, let's look at that left main.
Yeah. So my guide is out, so hopefully it's out enough. Little negative remodeling here. Not too bad.
I mean, the main itself doesn't look too bad. It just may be hard
to
hit the osteum exactly. So
right. And I think it's also basically there's a bit of negative remodeling, a little underfill from the disease being so much. So I would probably likely just stent the left main as well.
Okay. Anybody think he should do otherwise? Everybody agree with that plan? I think we got consensus here, Alan.
Okay.
Yeah.
Good. So we're going to do some measurements and then pick a stent, put it in, and maybe investigate a little further with the IVUS later.
Yeah, I think it would be. Yeah, I mean, why don't you guys go ahead and get your stents in, get your post dilating, everything done, and maybe a follow-up IVUS, and we'll come back. I hope.
Yeah.
To see you.
Okay.
All right. Thanks very much.
Thank you.
So we're moving to the other room.
Can we cine that a little bit?
Right.
Hello. Hey Terry, it's David Cohen.
Hello.
Here. How are you?
Hello, David. How are you?
I'm great. I'm
Okay.
here with my co-moderator,
I'm
Bang
Con here,
Ku.
so good to see you.
You tell us about your case. We're ready to go.
Okay, so thank you very much. It's a great pleasure to be here with you and to share this relatively complex case. Dr. Ozum Kwon will describe the story of the patient,
Okay.
and then we'll show what we have already done.
Okay, let me introduce the case. The patient is a 53-year-old gentleman, underwent the coronary angiogram for chest pain at the other hospital, which revealed stenosis at the proximal to mid-airway involving diagonal branch ostium as well as mid and distal RCA. So he was referred to our center for PCI. RCA was treated with the two DSCs and staged PCI for LA. The bifurcation region was planned. So he was treated RCA with the Zions. Next.
Great.
And he's hypertensive and he's hypertensive and hyperlipidemic, and he's a current smoker. And then he also has a hypertrophic cardiomyopathy with LV obstruction physiology. The patient presented with a stable angina. Syntax score was 14.
Okay, thank you very much. So maybe I can show you what we have done. So this is the first view that we have done. You can see that there is a tight stenosis of the LAD involving at least one big diagonal. So this is previous angio. Okay, so you can continue to describe.
Yeah, so we checked firstly this is the previous angiogram. The right side is a tight stenosis in the middle portion and the distal portion. Next. Yeah, RC. And so we treated the mid portion and distal portion to Zion's stent. The final result is, as you can see here.
Okay, that looks great.
Mm-hmm.
Okay, so now we can move to what we have already done. So you see on the screen the first view, areocaudal, showing this tight stenosis of the LAD. You can see it's a big vessel. We are working with a 7-French Cordis catheter, XB40. Next one. This is a cranial view. So you can see that there is also a tight stenosis of the diagonal. Yeah. And you can see that there is, in fact, 2 diagonal branches with a very early bifurcation. Next one. This is LAO view, so nothing more interesting in this view. Next one. And this is a spider view. I think the spider view is very useful when you have a lesion of a diagonal relatively proximal, especially proximal to the first septal, as you can see. So and you can see that there is, yes?
Yeah, so, I mean, the diagonal is clearly very, very severe at the origin.
Yes.
The LAD is, I mean, not as nearly as severe as the diagonal, at least any views that I've seen. I'm not sure if you see something different.
No, I fully agree with you. So we have a very tight stenosis of the diagonal, but in fact, you will see we have done some IVUS, and the LAD is also tight.
Okay.
Next one. So what I have done is I try to go through this diagonal first in order to secure the procedure. And with a run-through wire, which is my workhorse wire, it was not possible. Next one. So I used the filter FC. And you can see how it was difficult to go with the filter FC through this branch. I tried to go through the biggest one, but in fact it was completely impossible. It was surprising. You see, I tried, and very difficult. This is a filter FC. Usually, this kind of wire is very useful for this kind of lesion.
So you wanted to get into the second, the lower pole of that diagonal.
I wanted to go in the anterior one.
The anterior one.
But in fact, I was not able to do it. So finally, I decided to try the posterior one. And at the end, I succeed. It took some time, as you can see.
Thierry,
so which kind of wire you select in this situation?
Thierry, another approach would be use a crusade catheter.
Yes, of
and
course.
then bring in the XTR. You can try to.
Yeah. I think it's a very good point. I think the crusade is very useful in this setting. But finally, I succeed with filter FC.
Do you feel like you would ideally like to have 3 wires here?
Yes, of course.
Yeah.
Because you will see, but this posterior branch is at 3-0. Okay, you see, we finally succeed, but it was very difficult.
Yeah.
So then, next one. Next one, so this is the angiogram. Wow. Next one. And we decide to do predilatation. So this is a 2.5 non-compliant balloon. And you can see that there is a big discrepancy between the tube 5 and the real size of, of this vessel.
And
Next
that vessel
one.
is
Is
4.0.
huge.
It's huge.
So this is after a predilatation. So then I tried with a run-through wire to go through the anterior branch. Next one. It was relatively easy.
That's good.
And then I've done predilatation towards this branch. Next one. Oh, okay. So after that, we decide to do IVUS in order to understand the size, the lesion, etc. So this is first the IVUS in the diagonal branch, the anterior branch, which is the biggest one. And you can see that this branch is very big. So it's
5
4-0
millimeters.
branch.
Yeah. Wow. Okay. That's a big diagonal.
So this is something that I never see in France. I don't know why in Korea they have so big vessels, but it's good news. You see how tight is the lesion even after predilatation with a non-compliant balloon.
Now you're in the LAD here now?
Yes, so we have made the pullback from the LAD too, so let's move to the LAD. Okay, so this is the LAD.
Wow, that's big too.
Distal to the diagonal. Really unusual, huh?
Yeah. And they almost look aneurysmal, some of them, you know, a little bit.
Yeah, maybe some aneurysm, but not too much. Huh? So this is at the level of the bifurcation.
All right.
And you see there is a very huge plaque.
You convinced me
very
it's
big.
severe. Yep.
Yeah. And we have done, okay. So maybe we can discuss about the strategy in this case. What do you think?
Well, we have a big panel here. Maybe somebody smarter than me can, who wants to volunteer a strategy to take care of this? Anyone down this end? A lot of shy people. Hang on.
I'll take a shot.
Okay.
You had a lot of difficulty wiring that diagonal, and I know usually I'd like to start with a provisional strategy and make it simple with a single stent, but with the difficulty you had wiring that diagonal, I'm wondering maybe you're thinking of changing and treating the diagonal first and going for something like a DK crush technique here, especially if you've been able to secure the larger anterior division of that diagonal and stent into that. And the ostium of the inferior branch looks relatively clear there. So I think if we stent from LAD into the anterior division of that diagonal branch and do a DK crush technique, we'll be able to resolve the bifurcation issue and preserve both diagonal branches.
I just want to make sure we are talking about the same vessel here. So the anterior branch is the one that is superior in this view, right?
Yes.
That's the major diagonal, the most important one. It seems attractive. Anybody have a different?
Well, I think the posterior branch of the diagonal should be quite okay. If I think this case, I just stand on the anterior branch of the diagonal and probably using DK crush. But the problem is that how to select such a big stand for the LAD. I think it's a big problem. Maybe the Boston Scientific one maybe can be post-dilate to up to 5. That maybe possibly can be choose that kind of stand.
Yeah, size discrepancy is not. You have 4.0 in the diagonal, I guess, so you could use a 4.0 DES and.
You're also going to be using a kissing balloon
Terry,
eventually, so you'll get 2 big balloons in the
Your impression, Terry, was that from the beginning this was not for provisional standing, no?
No, of course. So I fully agree with your comments. Because of the difficulty to wire the side branch, I decide to treat the side branch first.
Absolutely.
Of course, it's not my preference, but in this case, we should do it like that because there is no way to. The risk of losing the side branch is very high.
So are you going to go?
Then we have.
I'm sorry. Go ahead, Terry, please.
No. Then we have different options. Deca crush can be a good option, but it will not be easy to crush this stent in a so big vessel. You can do a culotte also, but again, it's not very easy. So my plan is to do an old T-stenting approach, starting by stenting the side branch first.
So before that, do we have the LAD, the T-star, the IVUS dissemination?
You mean
The IVUS spiding, right? The
It was
LAD.
almost 6, I think, in the.
For the LAD.
Yeah.
Yeah. The only problem is that we have no 6.0 or 5.0 stent available in the cath lab, so we'll have to use a 4.0. So what I have selected is a 4.0 stent for this diagonal branch. I will take time to carefully position the stents. Okay, so too much proximal. And of course, I will do a provisional approach for the inferior branch.
Is it going to have a T stenting over here?
Yes.
Then maybe the posterior branch will be the angle will be more favorable.
Yeah, it's true. It's true. But the vessel is so big, so I think it's very acceptable in this case. We'll do an IVUS at the end if we have time to show it. Test again. Okay.
So this is not a very common technique these days anymore.
No.
Right, so
I agree.
showing the classic, classic T, right? So that
Yes, but you know this is not a common lesion, huh?
I agree with that.
Yes, it's so true.
I'm glad you're the bifurcation expert, not me.
Okay, so we do another angio. It's very important to be angio. Okay, so I think it's right. You know, I don't know if you see it on at the meeting, but the stent is not at the level of the markers. It's a little bit proximal and
just inside. Yeah, we can see we have very clear view, so we can see.
Okay,
well.
good. Okay, so I think I am happy with this position. I will do another one.
Okay.
Okay. It's too much proximal.
All right.
Okay, again.
Okay.
Angio. Okay. Okay, so let's deploy at 8.
All right.
So I go with low pressure because it's a 4.0. I don't want to do a carina shifting in the inferior branch. So 8 atmosphere, I think it's okay. There is still some waste, but it's proximal to the bifurcation. So what I will do is a proximal optimization technique with the same balloon proximal to the bifurcation. Okay, off. So in this view, I select this view because it's really the best that we have for seeing the trifurcation test. Okay, so I will make a cine just to be sure that we are. So it's very important to position the balloon at the right place, just proximal to the carina. So a little bit more distal. Again, cine.
Ready?
Yeah. Okay, so this is better. Okay, so now you can go to very high pressure, 16.
All right.
So it's semi-compliant balloon.
16.
What is the size? 16? 4.2. Okay, it's perfect. Okay.
Off.
Okay. So now we'll see what we have. I will remove the balloon because the quality on the angio will not be perfect. So do you have, I'm sure that many people are in favor of doing a crush technique in this case, or decay crush.
Thierry, what stent is this?
It's an Onyx,
Onyx.
Also on
4012.
So the reason why you selected not to perform the crush, whether it's DK or not, is that you may be afraid of leaving lots of room at the LAD because of it's too big, right?
Yeah. So you see, we have some pinching in the inferior branch, but we know, I think you will confirm that usually it's not functionally significant.
That looks pretty good already. That's good.
Yeah. And now I will deploy the stent in the LAD.
And you elected not to have a balloon protecting the LAD just because it's so large?
Yeah, we could. We could, but I'm thinking the vessel is so large, so I think that it will be okay. And so now we have 4022 Onyx stent. So the distal reference is 50, so we will have to post-dilate.
In France, do you have larger drug-eluting stents? This is the biggest we have in the U.S.
Yes, we have.
There is a 50 Onyx. They can go up to 575. Yeah?
Oh, okay.
Exactly. So as you suggest, you see that I feel
no.
some
Maybe a balloon,
problems
huh?
because we are in the curve. So I will do pre-dilatation before.
So David, your balloon is important.
Yeah, okay, so well, I'm sure a balloon will pass there. Kenneth, I know you love to use drug-eluting balloons. Any drug-eluting balloon
I have
strategy
a
here?
different approach for the two-side branch. I will use a scoring balloon because you will have a controlled dissection and treat each of this with a drug-coated balloon. You have a 4O drug-coated balloon. Then for the main branch, I just use a Onyx 50 and then post-dilate to 5.75 in the proximal end. Finish the job.
I think that phrase makes sense because if we have balloon dilatation, especially controlled dissection with the angioscore balloon, and if the IVUS shows that they not have a much ugly dissections, drug-eluting balloon may be an option for this case.
The drug-coated balloon, if you pre-dilate it with a scoring balloon, it works better than with a POBA, and this is shown in the ISA Desire 4 trial, where the restenosis rate is much lower if you use a scoring balloon before the drug-coated balloon.
Right, it's a good suggestion.
Again, it's so many tools that we don't necessarily have in the States, so I like to learn.
So you mean using the scoring balloon
in the diagonal?
Diagonal?
Yeah, without stenting.
Yes, and it's good to finish the diagonal procedure with the drug-coated balloon.
Yeah, okay. But the vessel is so big, I'm not confident that the risk of restenosis will be so low even after using a drug-eluting balloon.
Mm-hmm. So you feel better with the stent. So what size balloon is this now? Well, not going so
it's
easy.
3.5.
15?
Oh, still
15, yeah.
Still tough, huh?
Yes, still tough.
Yeah.
You have to go even smaller.
Yeah. Oh, we can do dilatation here.
Okay.
Want to go
16.
All right. 16.
Okay, off. Okay, so we will have to use a smaller balloon, I think.
2.5 balloon, maybe?
Yeah. Okay. So 2.5.
We had a 2.5 아까 나왔었던.
Well, this is why bifurcations are always tricky.
Especially when they are very big, yes.
Right.
We don't give you the easy ones.
So it may be a very trivial question, but you seem to use the sidewall guiding catheter. Is there any special reason for that?
Is it a sidewall?
Yes, you see that. Yes.
No, it's just because I didn't know that it was sidewall. I've never used sidewalls.
Okay, I see. It's clear.
Oh, my.
I don't like side holes because there is...
always taught not to use side holes in the left corner. You don't get this optimal angiography.
Okay. So you decrease the quality of injection and you have less support.
Okay.
There you go.
Good.
Yeah.
Is it 2.5? 2.0?
2.5.
2.5.
2.5.
Okay, good.
Test. Okay. Vas-y. Okay, go. So we'll go to high pressure and maybe post-dilate with a 3.5 just to be sure that the stent will go. 18, 20?
Okay. 20.
Okay, off.
So I guess...
So you know, Antonio Colombo invented the crush technique when he failed to do a classical T-stenting technique.
So sometimes accidents are useful.
Yeah.
Yeah. Were you going to say something?
We just
So the 3.5 balloon?
Okay, well, it is. Yeah, that was the comment. Now it's a mini crush, anyways.
I think it's smaller than mini, so I'll call it micro crush, because you're crushing only the one or two strokes of part of the
nano crush.
Right.
Nano crush, okay. Or pico crush.
What's the size of the guiding catheter?
7 French.
7. Yeah. So it's a good demonstration of, it's always good to have a parking balloon whenever you're doing a tap or a crush or mini crush, right? And, but it would be a little tight with big balloon and big stents.
Yeah, you're right.
Now it's easy.
Okay, we can go to 18 again.
This is your 3.5 balloon from earlier?
3.5, yes.
Okay.
Semi-compliant.
18.
Okay, off.
Migration.
We'll push a little bit more, yeah. Okay, go ahead.
Okay.
18.
All right.
So when you do a two stenting, which do you prefer, culotte or the crush in general?
T, I prefer T, but provisional, like a provisional T.
Mm-hmm.
But in this case, it was not a good option. The risk of losing this big side branch was too high.
In practice, what's your favorite stent for the bifurcation? Especially for the
it's a big question. I think today all the stents are very good. In my lab, we have Xience, Onyx, we have Terumo stents. So all those three are very good. But I'm sure that I think second generation stents today are very good for bifurcation.
Do you have a particular one you prefer for culotte, for the broad access to the side branch?
No, I think they are
They're all good for that too.
very similar, yeah.
So now you're bringing back the stent?
Yes.
Okay.
Okay, so now we will carefully position it. So of course it's very important to remind that we will have to do a pot proximal to the bifurcation. So I need to leave at least 8 millimeter. We have a 8 millimeter balloon, 5-0. Or 6-0.
And will you leave the wires while you do this?
Okay, we have,
yes.
we have 8.
No, after that I will remove the wires. So what, do you agree with the position? Maybe we can check in another view.
Yeah, I think the lesion was almost all proximal to the bifurcation, so I think
yes,
keep most of the stent proximal.
Okay, so it looks, okay, we can do a cine, but I think angio, okay. So
Seems
we hide
fine.
this.
Maybe a little more proximal?
Can we see it again? Yes, okay, I agree. So I will pull it a little bit back.
Yeah, that's,
Okay,
I think that's
cine.
good.
Okay. You agree with this position?
I like it. Anybody?
Yes, me too. Me too.
Everybody likes it.
Okay, so go to 12.
So all of us have some responsibility for this location.
So you will leave the wires for now,
8, 10, 12.
Yeah, because
since it's a T, I guess.
it's a C and the stand is too small.
So they won't grab the wires anyway.
Because distal reference is 5 and proximal is 6.
Yeah.
And this is a 4-0. So we can go to 18.
18.
What is the size at 18
18 is-
atmosphere? It's 4.3, something like that.
Yeah,
4.3. Okay.
Still undersized.
Okay, off. So now we'll use the 5-0 to post dilate.
For French.
So the only thing is that in this case, I'm not sure that we can do a kissing balloon with a 5-0 and a 4-0 balloon in 7 French guide.
Can you do a pot, side pot?
Yeah, so this is what I will do. Because I think it will not be...
L85 is
I think, Thierry, we have, after you finish this first post-dilatation, maybe take an angio, and then we will flip back to Alan's room for a little bit.
Yeah, of course. So we can do an angio now if you want.
Why don't you do your first pot and then
Okay.
then the angio.
So it will not be a pot, it will be a stent expansion, because the stent is too small. So we'll do a stent expansion with a 5-0, and then pot with a 6-0.
Okay.
So you're using almost the size of the peripheral intervention device, right? 5060.
Yeah, it's the size of the renal arteries. No? Is it?
Is inner.
Is it the 4-0?
5-0.
Okay. So we'll do a pot. It was supposed to be the 5. 5-0. 5-0. Okay. So we can go back in this view.
We are also ready for 6-0.
For cranial view. Is it the 6?
No, but we are ready for 6-0, but it's 5.
Okay. You can post dilate. Okay.
Okay, go.
14.
Okay. 12, 14. Floater, please.
Okay, off. It looks big, but this is the size of the vessel. Huh? Okay, 14.
Okay.
So the two wires are gel, but not really gel because reference is 6. Okay, off.
So it just mentioned that it is okay for this case because proxima is very big, so that the retrieving wire may not be a matter. Okay. So if the lesion is diffuse calcified lesion,
14.
would you rewiring and before the adjunctive balloon, or they just keep going?
Yeah, I fully agree.
What would be the advantage of leaving the wire?
18?
I mean, why not remove them?
I don't know. I mean, they
serve
as markers to rewire.
Okay,
I suppose.
It's just because we have more stability with 3 wires. But of course, I will remove it now.
So I think if you could take a good angio now, and then we'll switch over to Alan's room, and you can come back at the very end, and you can talk us through the final steps.
Okay. And we'll try to do IVUS if you have time to show you the final IVUS.
Great.
Okay, so are you ready for... so we go back to the spider view and...
So now you're going to do a pop.
And right now he's taking an angio.
So what do you think?
So angiographically it looks very nice.
Yeah.
So, but it's always tricky to evaluate by angiography alone.
Of course. So we'll have to work a little bit more.
I think I would probably now change the wires.
Yes.
So I think okay to go to the other room. Okay. Yeah. So I think we will let you work a little bit, Thierry. So far, very good, and we will try to come back at the very end for a wrap up in about 15 minutes.
Okay, perfect.
Good. Thank you.
Thank you.
Ivis and take a look.
Okay.
Alan, we're back with you. Are you guys? Where do things stand?
Well, this, as usual, the diagonal that you don't want to stent, they're usually closed. So that's kind of where we are a bit. Now, let me show you what we did, and you can give me some advice in terms of how much work to do here.
Okay.
So when we left you, we were stenting the mid portion, right? And then we IVUS. Let's show the IVUS.
You were remeasuring, yeah. That was where we left.
Yeah. So we were remeasuring, and it measured to be about 28, I think, and all the way to the left main. And we measured the distal lumen reference is about 2.8, and then the vessel is about 3.5. So we decided to do a 3.5 30.
Right.
resolute onyx. And basically what you see is using different angles to anchor or nail the ostium of the left main. Because in order to do that, you wanted multiple views. The iliocranial is always very good. And just to make sure that we have it, and we're adjusting a little bit, and then we inflate it, not very high pressure. I think we went to about
10?
12, I think.
12,
right. So that's the expansion.
Okay.
The reason is I'm a little concerned about the diagonal, and this is what happened. The diagonal, you can see the flow drops, and basically, to me, maybe 0 to 1 type of thing.
Did the patient have angina with that?
A little bit, but then kind of subsided a bit. So the question is then, we actually took a 3-5 non-compliant balloon and did a little pot proximal to that diagonal. Hopefully, it can facilitate us re-entering that diagonal. So that's what we did, and then we basically try a wire to see whether it can get into the diagonal. Which I used the run-through again to see whether it helps, but it didn't get through, so I changed it over to a choice PT. And basically, just when you came on, we did a 1.5 balloon into that diagonal branch.
Okay.
And this is what we see. So probably either we have it dissected, when we enter, we dissected the origin, which is very common in these very tight lesions, that basically the flow disappeared. So because the lumen is trapped by the wire already. So we basically wire, with this charge, the wire looks pretty free.
Yeah.
So that's the good news. But the bad news, obviously, the 1.5 didn't really establish blood flow too much. So the question now is that do we want to invest more time to really try to get the diagonal open, or should we just go ahead and try to optimize the left main LED first, and then come back and see what we got? We have a wire in the diagonal, so we want to do something, we can do it. But I think right now I just want to finish up the left main. All that stuff's done. With the wire now is in the diagonal, and we can use the rest of the time to see what we want to do to rescue it, but not waste too much time just playing with this thing while the other ones are not optimized.
Right. Okay.
What do you think?
Alan, how's the patient?
She's fine.
Okay.
She's no symptoms.
Go
If the
ahead.
patient's okay, then I think that's all right to do. I might have just gone to a 2.0 balloon, but I think, I'm not sure it's any better, so I think
exactly.
get the cells nicely expanded on the stent, and then that's clearly
Right.
more
So we're going
important.
to do a little IVUS just for interest, because you can see whether we actually indeed have placed the stent correctly.
So you're
And
doing
we can
IVUS now?
IVUS now.
Okay.
So show you something. Otherwise, you're going to just show me putting balloons in and things like that.
We like to watch you do that. That's okay.
It's kind of boring, right? So I want to show
No,
you something, see whether... This is always the case. I would say the diagonal branch or the side branches is always a little bit of a challenge in the sense that, the ones that you really want to approach with two-stent technique is easy. The provisional ones, sometimes it's like this. It's very difficult when it's completely gone. When it's just
Don't say they're so
flow
easy.
decrease-
You should be happy you're not in the case that Thierry is doing.
I haven't seen it. Is it...
Try it's a trifurcation, really complex diagonal. And the vessels are enormous.
Oh, we are in the wrong branch. Okay, at least maybe take a look at the IVUS into the diagonal. Okay.
All right, maybe look at
That's
it.
my plan.
You're right.
다이고널입니다.
Let's take a look and see whether we are in...
Maybe you can at least see, make sure you're in the lumen at least. Yeah.
Yeah. That was one alternative plan. You can see that we're actually in the lumen, maybe not in the lumen. Maybe that's 3 o'clock.
Right,
is the
so I think
lumen.
it's the false
Yeah,
lumen.
that's possible.
Yeah, exactly. So let's see if I can go any further down. Is that the true lumen at that point?
I mean, that's lumen.
That's
I think that's
false
lumen. I think that's...
Yeah.
The true lumen
I
is
think that's true lumen
compressed.
at 6 o'clock.
Yes,
Exactly.
that's a true lumen.
Okay.
So again, wiring these things could end up dissecting it type of thing. So the question is, are we entered into an area distally that we can actually recover, or is it kind of too late, too far gone type of thing?
I bet you can, with just some balloons, you'll see it and be okay.
Sorry. Yeah, let's do this thing. Okay. So I would just going to go in after that with the little balloon and just 2.0 balloon and just squish it up a bit and see what we see. If it is completely dissected forward and Y is completely false lumen, then obviously it's not so good. And we might have to quit at that point.
Okay. You're
So
going
we're
back
going
down
to IVUS.
the LED now?
Yep, the right wire. So we have to be careful that with the wire in the diagonal, we don't go too far. So this is just really the original main reason to show this case. It's really, putting a stent in the left main LAD is to just make it, nail it down well. And the side diagonal is kind of a side issue. Okay. So this is now distal to the second stent. Let's do a pullback. And see what kind of touch-up we need to do. And then we'll spend some time trying to see where they can rescue the diagonal. It looks pretty good distally, actually.
Distal looks great.
It's pretty expanded.
That was a 3.5?
That was a 3.0 Onyx.
3.0, okay.
26.
Now you got 3.0.
It expanded pretty well at, I think we did it twice, up to 16 atmosphere.
All right, yep. Mm-hmm.
Approximately, even if that's relatively calcified on 90 degrees, 180 degrees calcification area, looks pretty good. So we can measure an MSA in a little bit.
A lot of disease in
out
that
of the
segment.
stent. Yeah, there's more disease than I thought, throughout the whole vessel, right? So
Yep.
this is disease as well. You can argue some people may just cover it, but the plaque volume is not very large, but it's getting there. So that segment there is the tightest of the in-between stent area. So we want to make sure the distal stent area doesn't have a dissection or anything funny, intramural hematoma, anything like that. So that looks, landing zone is quite good.
Clean. That's clean. That's
It's clean, so we're just going to look the rest of it and look at left main. Maybe we'll peek into the diagonal. We'll get a 2.0 balloon to see whether they can open up the diagonal.
Yeah. You already have it.
You have it? Yeah. So this is a little small in the mid portion there, that near the diagonal. It's probably that part of the reason. There's so much plaque in that area.
Yeah.
Well, any little 3.5 stent is going to squish everything everywhere, longitudinally and radially. And that's sometimes very difficult to recover without putting a stent in. So we'll maybe make it a little bit bigger proximally here.
You certainly have vessel, yeah. It's remodeled there. Are you in the left main yet? I didn't see the circ yet.
Not yet.
Okay. Yeah, we are.
So now it's maybe
I was in the main. Yep.
Yep. Sorry. Can we play back a little bit?
Okay. I
Let
missed
me
the
just
circ.
go forward a little bit. Let's do one more time. I just want to see when we're talking, we just said the left main the guy was into the left main a bit. So we anchored it pretty good.
I think you got it within a millimeter.
Yep. Yep. So we're going to post-dilate the area, clean it up a little bit, and so that then we can set some time and see whether we can rescue the diagonal. I think the diagonal is probably dissected a bit there.
Yeah. I mean, your goal for the diagonal, if it were me, just get flow. I mean,
I know,
I'd
that's
like
not
to leave
much.
with flow. So.
Right, so that's the wire is pretty free, so hopefully distal end is in the true lumen. That's my hope. But again, it could be in all false lumen as well. Good.
Okay.
Yep. Let's post-dilate the left main.
3.5?
It was 3.5 before, right?
Yeah.
Let's at least 3.75 or 4.0.
3.75나
How about you go 4.0
4.0
here?
maybe. 4.0 please, maybe.
Yeah.
4.0 NC.
Yeah, you can see that David, you can see that diagonal here, that there's some pocket of contrast. The good news about it is that it clears.
Yeah.
So at least hopefully there's communication from false to true. And the guy cleared. If the pockets just stay there or track down the wire further, then I'm kind of say, well, it's history, right?
Yeah.
It's just too much. So here, hopefully there's a chance they put a little bigger balloon and squish backwards and squish some of that false lumen out and then see what happened. And again, as David said, I want to just reestablish flow and then see, at least, we don't have a closed vessel leaving the lab.
Is the patient stable?
Stable, no EKG changes, blood pressure of 180.
So it may be a very silly comment, but there's no evidence of, even if it's totally occluded, no ECG change, no patient symptoms, so what will be the reason for trying to reopening that branch? It's good to have an opening small branch, but
think it's, I mean, I would suspect you'll have a periprocedural MI if you don't get it open, even if she's not having symptoms and EKG changes. It's nice not to have an MI.
I like to be open. As David said, I don't want to be perfect. I don't want to look at it too much, but at least I want to have some flow.
Yeah, I
think
think
that area would be good, if I can. So you can feel a little bit of something there, except clearly the area needs a little bit of touch-up. So here, maybe inside. Okay. You ready?
So that's a 4.0 non-compliant balloon?
Non-compliant balloon. Yep.
8. 4.
Yep.
10.
10. Down.
Down. 3.9.
Okay. Okay. Let's go up to 16.
Okay. 14. 16.
I haven't actually been looking at the circ very much. The circ is all good, I think, right?
I think it's all good. The chest pain.
Yeah.
Okay.
During
One more time.
bonding. Okay.
16.
16.
Yeah. Okay. Down.
Down.
We'll try to get the origin of this thing. Best is go to the other view, but I think we'll just do it with
You can see
here
it.
like that.
Yeah.
Okay. Let's go.
Good. Yep.
Okay.
Okay.
16.
Down.
Down.
Good. I think we are good with that.
Yep. So I think if we can, if you're going to post-dilate the diag, we will stay around for that and see if it comes back.
Okay.
And then
we'll
finish
take
up.
two already, and then we will just pass it through and see what we see. Okay.
Yep. Sounds good. You just unwired the diag.
Oh no. I think it got cooked. Well, that means that we're not going to dilate it anymore.
Maybe that may tell you something.
Take a picture and then we'll go from there.
Let's just see what let's see what it looks like.
Picture.
Sorry.
Yes.
1 second.
Okay.
Oh, we hook everything.
Now you've unwired everything.
Let's take a picture. I think the wires are wrapped in a sense.
Something is telling us something here.
Tell me that I'm going to take the plane pretty soon. Ready?
Ready.
Look.
Yes.
we said all we wanted was flow.
Should we leave it alone, or do you think we need to do something?
I think you leave it alone. You got what we said we wanted.
No, I think you can see clearly that the pocket ends in the middle and then re-entry there, right?
Yeah.
Right.
So I think we'll be okay. I think we'll leave the flow going. We actually open up the vessel a little bit, if you may. And always be lucky than good, you know. Yeah. So I think I'm going to quit in terms of, I think my body's telling me I need to leave. So that's why I'm pulling the wire out.
No, I think that's great, Alan. Thank you for a very nice demonstration and complex procedure. Thanks.
Thank you. Do you want to take a look at?
So we'll go back to the other room. Hello, Thierry. We're back with you, and you get to finish up.
Yes.
Wherever you
so
are.
I will show you. So this is the result that we had just when you went to the other room. So I decided to rewire the diagonal with filter FC. Can you show it live? Well, not live, but...
Was it difficult this time or not so difficult?
It was very easy. Okay. After the pot.
The wiring.
Yeah, it's a video, so... Can you make it running?
You rewire with the run-through or with the filter?
Filter FC.
Field.
Can we see it since the beginning? Okay. So you see the shape that I have to do to go through, but you see it was very easy. Okay, next one. So then we we decide to pre-dilate first with a 3-0 to be sure that the 4-0 will come. Next 4-0. Next. So this is the 4-0 non-compliant, high pressure. Next. 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 And then we decide to do a repot. Next. So we have the 6-0 non-compliant, high pressure.
Wow, that's big.
Next. Next. So very important to position the balloon just at the level of the carina. As you can see, the shoulder should be really at the carina. Next.
So the end of the marker should be located at the Carina site, right?
Exactly. As you can see nicely with the stent. So now we are ready. I don't know if you have time. We are ready to do IVUS to show you the IVUS result.
We have about 4 minutes, so I think you can do that.
Okay. Okay, good. So we'll do the IVUS in the LED. Maybe we can do an angio at that time, because this is probably the final result.
So you simply didn't think you could fit to do kissing balloons? You weren't sure it would fit through the 7 French guide?
Yeah, I think it will not fit. I did not try it, but you know the 6-0 balloon, it's a peripheral balloon. So,
yeah, so that's a tough fit, yeah.
So we need maybe 8 or 9. But probably the...
And are you doing IVUS into the diagonal?
Into the LED, but
Into
we can
the
do it also in the diagonal. Huh? Okay?
Learn.
Okay, put a little bit more distal. Okay.
All right. Learn.
So you see how this vessel is big, huh?
There's 1, 2, 3, 4, 5, yeah.
Okay, so the stent is well opposed. It's a good size.
And this was the 4.0 stent. You took it distally to 5 and approximately to 6. Yeah.
Yeah. So now we are approaching the Carina. I don't know if you will be able to see it.
You can see the dropout there.
Yeah.
This is the Onyx stent?
Yes. Where are we? Okay. But you can go to up to 6 with the Onyx, huh?
That's a nice tool then.
What's the optimal duration of antitherapy in this case?
The optimal?
Antiplatelet therapy in this case.
I think it's classical antiplatelet therapy. I suggest 1 year because the patient is young and the risk of bleeding is very low. So 1 year DAPT, I think it's okay. So what do you think of the result in the LED?
To me, it looks great. I mean, everything looks opposed. I can't really tell the diagonal. That's the only thing.
So do you want to see the diagonal?
It would be nice if you have the time. I think we have 2 more minutes.
Okay, so we can.
Everybody would like to see how well you got the ostium.
Yes, a good point. I think for me the only remaining question is should we open the strut toward the inferior branch?
Well, I don't. Anybody want to do any dilation out the side of the diagonal stent? Not a lot of nodding here.
Okay.
I would agree with that. I think it's not. That's a of all
so
the vessels
EKG is normal. There is no.
Just not that important compared to everything else.
Patient had no chest pain. The EKG is normal, so I think it's okay. Okay. So you see, very easy to cross.
Good.
And we are ready. Okay, so we can start.
And this was this also 4.0? I've forgotten.
Yes, 4.0. It is
4.0.
So you see the stent?
Yeah.
Well opposed.
Nice.
Well expanded too.
1, 2, 3, 4.
And it should be a little bit bigger, close to the. Okay, so now we have the Carina. It's bigger, and now we are in the LED.
Well, looks perfect to me.
Okay.
I think it's great. No, I think it's a wonderful example, a very challenging diagonal branch. I can't think of anybody better to do it, so I'm glad we had you here to lead it, Thierry. And again, thank you so much for your expertise and for teaching us.
Yeah. Okay. Thank you for your support. Thank you to the team, which was very helpful.